Hey everyone, Dr. Jamal Farhan here, and welcome to Mad Jam. Today, we're tackling one of the biggest, most debated topics in our field. I'm talking about extracting teeth for orthodontic treatment. It's a huge decision, right? It affects our patients in a big way. So in this explainer, we're going to build a really clear, evidence-based framework to help you make that call with confidence. I mean, this is it, isn't it? To extract or not to extract? This is the question we face, sometimes every single day. It's a true clinical dilemma. You've got the goal of that perfect, beautiful alignment on one side and the principle of keeping every single natural tooth on the other. And whatever path you choose, you know it's going to have long-term consequences for everything: function, stability, and of course, how the patient looks. And look, this simple truth is there's just no magic formula here. No one-size-fits-all answer. It's so specific to each and every patient. We really have to be detectives, you know? We've got to weigh everything. How severe is the malocclusion? What's the skeleton doing underneath? And what does the soft tissue profile tell us? Only then can we figure out the absolute best course of action. All right, so how do we tackle this? How do we navigate all that complexity? Well, we definitely can't rely on guesswork. We need a system, a reliable step-by-step approach. Think of it like a diagnostic toolkit that helps us gather all the evidence we need before we even think about committing to a treatment plan. And this is our roadmap for today. Our whole diagnosis is basically built on a few key pillars. First, we've got the clinical parameters. That's what we see when we're looking right at the patient. Then we dive into a detailed model analysis. Now, of course, a full Ceph analysis gives us even deeper skeletal insights, but for our purposes today, we're going to focus on how these first two pillars give us a really comprehensive picture to guide that big decision. Okay, let's kick things off with that first pillar, the clinical assessment. This is ground zero. It's where the whole journey begins, with the patient sitting right there in your chair. It's all about careful observation and really understanding the face as a complete picture. And when we're doing that clinical exam, we're zeroing in on these four crucial areas. What's the overall facial appearance and balance like? What is that soft tissue profile telling us about lip support? Is there any asymmetry we can spot from a midline deviation? And maybe most importantly, is this patient still growing? Now, what's really cool is how we can start to put some numbers to aesthetics. A classic tool for this is Rickett's E-line. You just draw a line from the tip of the nose to the point of the chin, and it gives you a great reference for lip protrusion. But we also have to remember that what's ideal changes over a lifetime, and adolescents' lips are naturally going to be fuller and closer to this line than an adult. The lips themselves are a huge piece of the puzzle. If you see a patient with tight, strained lips, extractions can be a game changer. They give you the space to pull back the incisors, letting the lips relax into a more natural position. On the flip side, if a patient has really flaccid lips with poor muscle tone, you'll probably want to avoid extractions. Taking teeth out would remove crucial support and could give them that dished-in look, which nobody wants. Next up, we're looking for symmetry. A dental midline that's off-center from the facial midline is a major red flag. If that deviation is significant, especially when the issue is in the lower arch, it's a strong indicator that we might need an asymmetric extraction pattern to get everything centered up and looking great. And this is a big one. For our younger patients, growth is like our orthodontic superpower. If they're still growing, we can often use functional appliances to help guide how their jaws develop. And you know, a lot of the time, good growth modification can create all the space we need, taking extractions right off the table. All right, let's move on to our second pillar. We're shifting our focus from the patient's face to the nitty-gritty details of their dental models. This is where we really start to measure things up. So the very first thing we do with the models is measure crowding. A classic, reliable way to do this is with Carey's analysis. It's a simple calculation that tells you the difference between the space you have in the arch and the space you actually need to get all those teeth lined up perfectly. And this is where the numbers start to give us some real direction. As you can see here, if you've got a mild discrepancy, let's say 2.5 millimeters or less, you're almost always looking at a non-extraction plan. Once you get into that moderate range, 2.5 to 5 millimeters, that's when you start thinking, maybe second premolars. But when you're dealing with severe crowding, anything over 5 millimeters, extracting those first premolars often becomes the most predictable way to get a great, stable result. This brings us to a really fundamental concept in orthodontics. You know that natural upward curve of the lower teeth? That's the curve of SPE. The thing is, to get a stable bite, we have to level it out. And leveling a deep curve actually uses up space because it pushes the front teeth forward. So it's simple. The deeper that curve is to start with, the more space you're going to need to flatten it, which makes extractions much more likely. Finally, on the models, we have to look at the teeth themselves. A Bolton analysis is all about checking the size ratio between the top and bottom teeth. If you have a big mismatch, like the lower teeth are way too wide for the uppers, it can be impossible to get a perfect bite. If that discrepancy is too big to fix with a little bit of enamel stripping, then yep, an extraction might be the only way to solve it. Okay, so we've done our clinical exam, we've analyzed the models, now we have the evidence. The next step is to weigh the pros and cons of each path forward. Let's put them side by side. The non-extraction route obviously has some great things going for it. It's less traumatic for the patient, treatment can be faster, and you preserve that natural facial fullness. But the extraction approach has its own set of superpowers. You often get much better long-term stability, it's fantastic for correcting a protrusive profile, and in those really crowded cases, the results are just more predictable. But to be fair and balanced, we have to talk about the potential risks of extraction too. If it's not managed perfectly, you can see things like the lower front teeth trying to crowd up again, the overbite can get deeper, and you could even have some negative facial changes if you flatten the profile too much. It's all about having the right mechanics to avoid these problems. So this table kind of lays out the classic recipes for extractions based on the type of bite problem we're seeing. If you've got a class 1 case with just a ton of crowding, removing all 4 first premolars is a really standard approach. For a class 2, you're typically looking at taking out 2 upper premolars to help correct that overjet. And for a class 3, yep, you guessed it, 2 lower premolars are often the key to the puzzle. So after all that, after we've gone through our entire diagnostic toolkit and weighed all the outcomes, how do we make that final call? What's the guiding philosophy that we should bring to every single patient consultation? Well, here are the big takeaways. First and foremost, this is always a case-by-case decision. A thorough diagnosis isn't just important, it's non-negotiable. And while sure, a non-extraction approach is often the more conservative, preferred option, we have to have the clinical courage to recommend extractions when all the evidence tells us it's the only way to get a stable, beautiful, long-term result. And this, right here, might be the most important thing to remember. We can't be dogmatic about this. Extractions aren't inherently good or bad. They are simply a tool in our toolkit. When you use that tool correctly, for the right reasons, it can lead to absolutely incredible treatment outcomes. The key is mastering the diagnosis so you know exactly when and how to use it. I really hope this systematic approach gives you a useful framework for thinking about this classic orthodontic debate. Here at MedJam, our whole mission is to provide clear, concise medical and dental education. Thanks so much for joining us today.